A 34-year-old at 15 weeks of gestation, hepatitis B surface antigen positive, you want to know replication status, chance of infectivity. Obviously, it is the envelope antigen which will give you an important clue. Postmenopausal woman who is having intense itching around the vagina and anal area, you will basically think of lichen sclerosis. 59-year-old with constant weakness from her vagina after a hysterectomy. Hysterectomy is a risk factor for what complications that lead to incontinence, Dr. VVF, vesico-vaginal fistula. So that's the reason you need to do the dye installation of the bladder and try to check whether it is present. 36-year-old being induced for preeclampsia, delivers a 5 kg baby, and because of that she is having a postpartum bleeding. So what is the best therapy in that given scenario? Because of that she has got a non-reducible uterus, so you need to relax the uterus. So there is a reason you need to give halothane anesthesia. 32-year-old G to P1, 40 weeks gestation, has progressed from 5 to 6 centimeters over 2 hours. So how do you like to describe this labor as? Once more, definitions of different types of abnormal labor. Protracted active phase. How do you define protracted active phase? Some progress but less than expected. That is 1.5 centimeter per hour. During the active phase of the labor become protracted active phase. In this case, patient is more than 4 centimeter dilated. So since she is in 4 centimeters, she is no more in the latent phase of the labor, she is in the active phase. And we like to call this as an arrest of the active phase. If at all there would have been no progress at all, then we would have called it as arrest of progress. Cervix has changed from 1 centimeter over 2 hours, so the expected change would be 3 centimeter. Therefore, this is treated to be a abnormal labor. So that's the reason, doctor, that one table hai na, arrest of descent, arrest of active phase of labor, everything you need to review. 39-year-old wets her underpants 2 to 3 times each day. Yeah. Next question. Why not prolonged active phase? I'll just I didn't get time to go through the table. I'll check that. We'll add it up. Yeah, 39-year-old is having wetting of the underpants 2 to 3 times each day. She feels that she needs to void but cannot make it to the restroom. Before that only she will have the wetting of the underpants. So what is the cause? Urge incontinence. If she laughs loudly and happens to wet, you call stress incontinence. So types of incontinence you must be very clear. Urge incontinence, what is the problem with the bladder? Bladder is very spasmodic. You have to relieve the spasm. So how will you release the spasm? You need to use something that relaxes the spasm. So we use the oxybutynin, which is considered to be a better choice. 59-year-old undergone total hysterectomy for uterine fibroids 12 years ago and taking supplemental calcium. What do you want to screen in her? So basically, if at all hysterectomy was done for a benign cause or for a malignant cause. If it is for a cervical dysplasia or cervical cancer, then cervical cytology of the vaginal cuff is required. But if at all the hysterectomy was done for a benign condition, then the cervical cytology of the vaginal cuff is not required. One more criteria. Earlier pap smear was abnormal and hysterectomy was done. Then post hysterectomy the vaginal cuff need to be repeated pap smear need to be done. So then another situation. Abnormal pap smear is there, but there is a benign pathology and no cervical cancer, but the patient uterus has been removed. Then also you need to do abnormal pap smear height to be, you have to do the repeated smear is what need to be remembered. So what was given in this case? Uterine fibroids. So the pap smear, uterine fibroid is a benign pathology, it is not cervical cancer for which it has been done. So no need of doing pap smear on the remnant cuff. 51-year-old with oligomenorrhea and hot flushes. Ovarian failure is the underlying cause. 36-year-old and her abdomen is showing tenderness, guarding and without guarding and rebound, tenderness is only there and receiving methotrexate as a treatment of ectopic pregnancy. What is your standpoint? Beautiful question. So whenever methotrexate is given for ectopic pregnancy post management, patients will have abdominal pain, but that doesn't mandate you or alarm you that you left something or missed something. But if guarding or signs of hypotension or any signs of rupture are there, then you need to intervene. Right? Methotrexate by itself will lead to some amount of abdominal tenderness when you have administered. So ectopic pregnancy management, medical management, that way is challenge. Post medical management, abdominal pain is there, you have given methotrexate, you have to really sit and wait whether rupture will occur. So that is sort of challenging situation only, but observation is okay. Now, chloroquine exacerbates psoriasis, as all of you know very well. Now, coming to the placental abnormal implantation. Posterior placenta is associated with less risk of accreta than the anterior placenta is a true statement. So I leave to you the literature. What predisposes to the development of an abnormal placental accreta, abnormal implantation? Increasing number of caesareans and placenta previa, etc., they are all the risk factors. 22-year-old uses a barrier method of contraception and she is having abdominal tenderness, dyspareunia, etc., and a hyperemic fallopian tubes, pelvic inflammatory disease. What is the most important organism implicated, doctor? Chlamydia is the one, salpingitis may implicated. Now, 36-year-old, 10 weeks of gestation is having vaginal bleeding and passing whitish substance along with something which is meat-like and 2 cm dilated cervix. This is a typical description of what you call as incomplete abortion. Incomplete abortion, how do you manage? Dilatation and curettage is considered to be the management of choice. Shoulder dystocia. What is the important risk factor? Big baby because of the maternal diabetes. Then for the delivery of the posterior fetal arm, what is the mechanism which is available? I mean, how do you basically hasten the labor? It decreases the fetal bony diameter from the shoulder to axilla. That's how you will basically hasten it whenever you do the delivery of the posterior arm. Eclampsia doesn't include, these are prodromal symptoms. When actual eclampsia occurs, you have convulsions as a part of diagnosis, not the prodromal features. Coming to oxytocin. Oxytocin is a 9 amino acid peptide, not decapeptide, and a half-life of about 3 to 4 minutes is a truth. Coming to the prenatal diagnosis, what is accept about it? The very common way by which you do for all genetic disorders the biopsy would be the Blastomere biopsy. So it does not, it involves removal of 2 blastomeres where the embryo reaches the 8 cell stage, typically during the 3rd day of the development. So you want to know, doctor, the baby going to be born is a future AP PG topper or not? Blastomere diagnosis if you do, will it lead to miscarriage? No. Most common form of the biopsy done, fetal biopsy, would be the blastomere biopsy. Now coming to the infants born to the diabetic mother, they will have obesity, ketotic hypoglycemia, future diabetes risk is there, but not learning disabilities, luckily. Right? Then what is the commonest cause of first trimester abortion? Trisomy or triple ID? Trisomy. Then Bishop score, you must know cervical dilatation, length of cervix, station of presenting part, consistency, blah blah blah, everything you must know. Eisenmenger is very bad. If there is a pulmonary hypertension and development of a right to left shunt with a cyanosis, absolute contraindication for advising pregnancy is what you need to remember. Now doctor, primary oocyte etc., you must know the structure. Primary oocyte typically has 46 chromosomes. It has 23. And then you have mature oocyte etc. etc. Asymmetrical versus symmetrical growth retardation, which is more dangerous between the two? Asymmetrical IUGR is more common. Asymmetrical IUGR is due to the extrinsic factors that affect the fetus during the later part of the gestational age. High BP in the mother, severe malnutrition, any genetic mutations, Ehlers-Danlos, they lead to asymmetrical IUGR. Symmetrical IUGR is less common but more worrisome, because the factors leading to that are intrinsic to the fetus, not extrinsic. And intrauterine infection, anemia, chromosomal abnormalities, they all lead to symmetrical IUGR. This question straight will come in entrance exam, right? So you have to review. Okay, doctor. Today I am very going in my first gear, slowly, but common cold, I can't take Sunday class means what kind of competence I am teaching my students. We want our students with common cold, cerebral malaria, encephalitis with hydrocephalus to go to the reading room and read. Right, doctor? When you feel you can't do during that time, if you do, that improves your confidence to do forever. Any procedure also, right? So, but not during interventions in hospital. Sometimes you will try to put a IV line, simple IV line, you don't get, you poke. Don't do that. Leave it. Ask your nurse to do. No ego. Another instance, when no one is able to get, you will get the line. They are different. But post night duty, when your legs are aching, your voice is choking, you have to treat a patient of acute MI. Still you stand there and do that. You do that few times, you will discover that you are born for doing that. That's what is important. Okay, doc? So don't say, I have to read psychiatry, I have to remember dermatology, I have to remember radiology. You have to, you will. Because people who remembered and did not run away on the stupid name called boredom are the ones who won ultimately. Those who say boredom hai, padhai mein kya hai, what is this, notification nahi aata, CM aisa baat karta, wo sab bakwas ki baat hai. Don't waste time. When you are, सबसे बड़ी चीज क्या होता है? जिंदगी के सबसे बड़ी चीज नहीं गिरने में नहीं होता, मगर गिरकर हर दफा उठने में होता है. Every time fall, rise and win. Shoulder dystocia. Where is it common, doctor? So post-dated pregnancies may typically the baby is big enough to come out, predisposing to the shoulder dystocias. In India, hemorrhage, blood banks are the most important, the need of the hour. Hemorrhage is the most common cause. Compound presentation कैसे होता है? Most commonly, head and hand baby want to come out, right? Head and hand, not head and foot, head and cord. Anybody answer head and cord? You check it. This is a very well checked answer, but you please do check it. Now, what is the dose of the anti-D that you want to give? 300 micrograms. Once more, that Lilly's curve, clean Hoyer count, RH isoimmunization ka pura superb questions will be there. वो सब पढ़ना है, कितना doses देते हैं, depending upon how much ml. At that level, you have to be ready for exam. Gynox doctor, don't say it is a tough subject. It's a stupid subject. I'm telling you, no, you will get 30 out of 30. कुछ भी डरने का जरूरत नहीं. For that matter, there is no need of fearing about any topic, any subject. No subject you need to fear. Only thing is, few subjects will have few numericals little more. That make you little worried. Imagination is more like ophthalmology. That make you worried. But limit yourself to 20-30 topics. Pakka padho jao. Invest on your time. But please review this. Obstetrics. Then in active management of third stage of labor, methyl ergometrin is given. Earlier they used to give. Nowadays the protocol says anterior shoulder ke baad giving is not good. To deliver and then post delivery you try to administer is the modern buzzword. So physiological management versus active management of the labor ke farak kya hota hai? The table you have to be very clear. So it is up to 20 weeks you are permitted to do the MTP. So thank you doctor for giving us courage to review the 200 questions. Next week we will meet with more energy. Thank you.